Alright guys, doing the Critical Care Journal Club today. Alright, so it's going to be Critical Care Journal Club. For everybody who doesn't know me, Mohammed, one of the Plum Fellows, second year. We're going to be doing our journal club, so I don't have any disclosures to give you guys. So overview for today, we're going to be giving you, so the article is this vitamin C and sepsis. And we're going to start off with the background on sepsis and vitamin C, and then we'll talk a little bit about the author and the study rationale, and we'll talk about the study itself, and then hopefully have a discussion afterwards as to who wants to do it and who doesn't. So the article itself is hydrocortisone, vitamin C, and thiamine for the treatment of severe sepsis and septic shock. It was published in December 2016. So just some background on sepsis. More than 1.6 million people in the U.S. are diagnosed with sepsis in each year, 1 in every 20 seconds, and the incidence is rising about 8% each year. It's the leading cause of death in U.S. hospitals. 258,000 deaths annually are attributed to sepsis. And it's the number one cause of readmissions to the hospitals, costing more than $2 billion each year. So what exactly does vitamin C do? It treats scurvy, but other than that, it actually is a potent antioxidant that directly scavenges free radicals, oxygen-free radicals. It restores other antioxidants and macrophage functions, and it's a cofactor for iron and copper-containing enzymes. Now, what people have shown in experiments is that in the setting of sepsis, there is a subnormal vitamin C levels in plasma and leukocytes. And there's actually inverse proportional relationship with vitamin C and multi-organ failure, and directly with survival. So why do vitamin C levels drop in sepsis? The proposed mechanisms currently are because when patients are sick, we're not giving them enough vitamin C in their diet or parenteral nutrition. And the other more plausible effect is increased requirement, likely due to oxidation of ascorbate by reactive oxygen species. So Dr. Paul Merrick, he is currently a professor of medicine and chief of pulmonary critical care medicine at Eastern Virginia School of Medicine. He is a critical care physician that has written about 4 books, and he's got 400 articles, several in New England Journal of Medicine. What happened was he was caring for 3 patients that were diagnosed with fulminant sepsis that were, according to him, at maximal therapy. We don't know exactly what that means, but he was at maximal therapy, and at that time they were, according to him, destined to die. So he attempted an experimental treatment. What that was he gave IV vitamin C and hydrocortisone. The patients made a dramatic recovery and were discharged from the ICU within days, and there was no residual organ dysfunction. So from there starts that his hospital kind of just changed their protocols and started IV vitamin C in all sepsis patients. So exactly how he proposed the mechanism was steroids and vitamin C. They apparently have a synergistic effect. They downregulate production of pro-inflammatory mediators. They increase tight junctions between endothelial and epithelial cells. They preserve endothelial function and microcirculatory flow. And they're also required for the synthesis of catecholamines and increased vasopressor sensitivity. That's what he suggests. That's the proposed mechanism as to how they have a synergistic effect. And exactly why he added thiamine to the cocktail was there's glycoxylate is a byproduct of metabolism of vitamin C, and it can either be reduced to oxalate or oxidized to carbon dioxide by the enzyme glycoxylate aminotransferase. So thiamine pyrophosphate is a coenzyme required for this reaction, and thiamine deficiency, it's common in sepsis, and it increases the conversion of glycoxylate to oxalate. So potentially oxalate crystals form and can cause some renal dysfunction. So getting to the article. So the methods, it was a retrospective before-after study. It was a single center, only in their hospital. Patients were admitted under the critical care medicine service in the general ICU. And then there was two groups, obviously. The control group was followed for 7 months, June 2015 to December 2015. And the treatment group was from January 2016 to July 2016. Their inclusion criteria was all patients with primary diagnosis of severe sepsis or septic shock, and all patients had a procalcitonin of greater than 2 nanograms per milliliters. I think our procalcitonin levels are done on micrograms per liter. That's why it would be, I think, equivalent to 0.2 for us. The exclusion criteria is patients under the age of 18, pregnant patients, and patients with limitation of care. So on their study, they specifically mentioned anybody that was DNR, DNI was not included in the study. That's a small study, 47 patients in each group, so 47 in the treatment, 47 in the control group. There was no significant differences in baseline characteristics, that age, sex, or comorbidities. The most common sites of infection that were seen in the study was lung, urosepsis was second, and bacteremia of unclear etiology was third. Blood cultures being positive in 28% of patients. The most common organisms were E. coli and gram-positives. Vitamin C levels were attempted to be drawn prior to starting therapy. And immunocompromised patients, the definition that they gave was anybody taking prednisone more than 10 milligrams daily for at least 2 weeks, or receiving cytotoxic therapy, or diagnosed with an immunodeficiency syndrome. Just going back to that vitamin C level, so they actually didn't report in their study what the vitamin C levels were before and after, or like the duration of 72 hours. But just FYI, less than 25 milligrams per liter is considered deficiency or hypervitaminosis C. So this is what they were just talking about, the table 1 characteristics. So the age, as was mentioned, there was no statistical difference. So 58.3, 62.2. The comorbidities, the most common ones were diabetes, hypertension, and heart failure. The two most common were pneumonia and urosepsis as far as the primary diagnosis is concerned. The amount of people that required vasopressors, just because they listed it on here, was 46% on each group. And the amount of people that required mechanical ventilation right above that was 47% and 55% of patients. Again, their predicted mortality, which is the last row, is actually about 40% for each group. And that's dependent on the Apache score, Apache 4. So what they did for both groups was that as soon as the diagnosis was confirmed, they received broad-spectrum antibiotics and were de-escalated depending on the microbiological data that they received. The volume status that was provided was a conservative fluid strategy and vasopressor strategy. So Dr. Merrick, he recently had an interview with Medscape, and he mentioned that he is not a believer in that 30 mLs per kilogram. He says it's more detrimental and harmful, so therefore they gave a conservative fluid strategy. So as you can see, in 24 hours, there were 2.1 liters positive in the treatment group and about 1.9 liters in the control group. And at the end of 72 hours, 1.9, 1.6 respectively. So norepinephrine was the vasopressor of choice, and if they were not able to achieve a MAP goal of 65 or above, then they went ahead and added vasopressin to the mixture. So mechanical ventilation was provided as a protective lung strategy. They received limited use of sedatives, and Precedex was their go-to medication if possible. Enteral nutrition was started about 24 hours after ICU admission or hemodynamic stability. And DVT prophylaxis was enoxaparin. If patients had a creatinine clearance of less than 30, then they used heparin and SCDs. The treatment group, the regimen that they got was vitamin C 1.5 grams every 6 hours for 4 days, hydrocortisone 50 milligrams Q6 hours for 7 days, and then thiamine 200 milligrams every 12 hours for 4 days. Actually, this was until either they got the 4 days or until discharge from the ICU. So the data collection basically included just getting just your labs as we would on a daily basis for the first 4 days. Their definition of an AKI was a little different. So they defined it as a serum creatinine of greater than 0.3 or a level 1.5 times their base value. Creatinine 1.5 and above without a known baseline was deemed indicative of an AKI. So that was their AKI definition, and they used Apache 2 and 4 scores were recorded. SOFA scores were done at 24 hours, and then daily for 4 days as well. As far as comparing the two groups, they did use propensity scores to match the patients, just to make sure the study population was appropriate, and it was showing the likelihood of receiving vitamin C. So from here, it looks like lactate, procalcitonin, and creatinine. Where's the 3? The primary outcomes that were measured, so hospital survival. Control group, it was 19 out of 47 patients, so 40% mortality rate. And the treatment group was 4 out of 47 patients, so 8% mortality rate. And there was a statistically significant p-value at less than 0.001. The predictors of mortality that they found were the vitamin C protocol, Apache 4 score, and the need for mechanical ventilation. According to the study, in the treatment group, nobody died with complications of sepsis. They said the cause of death were advanced dementia, severe heart failure, advanced sarcoidosis, and severe COPD. But they didn't mention exactly what the causes of death were in the other group. Now, one thing that I just have to add is that 28 patients in the control group did receive hydrocortisone as well as part of their treatment. This is just a graph showing that the predicted mortality based off their Apache 4 score, which is in the red, and then the actual mortality, which is in the blue. As you can see, there's a significant difference in the control and the treatment groups. Their secondary outcomes were the duration of vasopressors, ICU length of stay, renal replacement therapy, and AKI, the trend of procalcitonin over 72 hours, and the SOFA score over 72 hours. So, as you guys can see, the ICU length of stay was not statistically significant, so it was 4 days, so there was no decrease or increase in regards to the treatment or control group. The duration of vasopressors was significant, 18 hours compared to 54 hours from the treatment group and control group. The need for renal replacement therapy, 10% versus 33% of patients. And again, these are also statistically significant numbers. The SOFA score change, which is 4.8 versus 0.9, so that's highest versus lowest, and they just got the median. And then procalcitonin clearance, 86.4 and 33, so that would be kind of 0.8 and 0.3 in our values here. All right, and that's just kind of showing in a graphical form actually everything that we just talked about, how the procalcitonin downtrended in our treatment group, which is the red, and the control group, which is the blue. This is the SOFA score, how it downtrended, and the line in gray dotted is the control group that patients have died. Same thing for the vasopressor duration. Again, it was 18 hours versus 54 hours as far as coming down on the vasopressors. And as you can see, the control that obviously went up in that category. So as far as the limitations in this study were concerned, it's a very small sample size. It's a single center design. Treatment and control periods occurred during different seasons, although, like I said before, the patients were propensity score matched, but they did occur in different seasons. There were non-concurrent control subjects over the course of the 7 months that they enrolled. And then they used too many variables at one point of time, so they don't know if it's like impossible to determine whether or not it was one thing or the other that caused the improvement in outcome. So this is Dr. Merrick's own words that he, there's, because of withholding life-saving interventions. They did not propose doing a randomized control trial, so it's kind of at phase 1, and then they kind of stopped before any other phases were even done. So that's another limitation of the study. And then there's more study that needs to be done in contributing role of thiamine as well. So I guess the question now becomes to all of us is that what will we be doing in regards to managing sepsis? Will we change our management? I guess is the question. How strong is the evidence? It's actually not that strong. It's pretty weak. It's 47 patients in each group. It needs to be done at a higher level. It needs to have more patients. It needs to be a randomized trial. That might be a little difficult because these are inexpensive, readily available medications, and as to who will be funding that might be the question. But there is currently one trial ongoing. It's not similar, but that's in phase 2 currently. It's vitamin C infusion for the treatment of sepsis and acute lung injury. They have received a grant from the NIH. Virginia Commonwealth University is currently doing it. And their primary outcomes is change in SOFA scores over the course of 96 hours if they infuse vitamin C. And then they also will be checking C-reactive protein and thrombomodulin at study hours of 0, 48, 96, and 168. There's also another study that's ongoing as well, so which we'll talk about right here. So the one thing that Dr. Merritt kept on mentioning was that vitamin C is not harmful to patients. That's what the small studies that have shown. So all studies that have been done have been very small populations, whether it's 20 to 30 is the sample size. The vitamin C doses that they did study during this study was about 6 grams in a day, and since 1949. It's been kind of, all these small studies have shown that there's no detrimental side effects. And when they did give thiamine to those patients, apparently, the oxalate crystal formation was decreased. Now, as far as vitamin C is concerned, yes, but steroids, it's another ordeal. If we're going to be giving it as a cocktail, then steroids do have adverse effects. There's actually an ongoing trial in New Zealand and Australia that have enrolled about 3,800 patients, and it's phase 4. Currently, and that trial will give us more information as to what the detrimental effects are with hydrocortisone. They're giving 200 milligrams to each group, or 200 milligrams to the treatment group, and D5W to the treatment or control group. And then, like I said, it's in phase 4 currently, and we'll see what that actually shows. So it's a very small topic. So I actually wanted to just open it up to people here. What do you think, Dr. Rivers? If you had any opinion on this?
Well, I know Dr. Barrett very well, and he got on NPR and basically was able to get this out there. So when you look at Twitter, you look at social media, you look at how research is disseminated. 10 years ago, this study would not even been quoted. Mm-hmm. Because just look at it, it's for patients, and granted the mortality reduction is there, but as you know, it's far from legitimate science. And so I think it's just a characteristic of how research is disseminated now. There's no peer review. This article actually was submitted to New England Journal. It was turned down multiple journals, and it ended up in Chess. But I think the reason why it got out there is simply because the person is very bombastic. You put a microphone in front of them, you have to pull it away from them. And so it's just the nature of that. I think it's very good in terms of, perhaps needs to be discovered in the future, but the steroid issue, as you know, there's been no randomized trial that shows steroids to be beneficial, although I truly think it is. I think it comes down to patient phenotyping, clinical phenotyping, therapy in terms of, does the patient need vitamin C, does the patient need iron, does the patient need steroids? And I think that once we can clinically phenotype these patients and put them into categories, I think there may be some beneficial effects. Because, in all the studies that have been done, there has been some hemodynamic improvement with the use of steroids, even with thiamine. It is an inotropic substance. So there's some what we call physiologic benefit from these things in patients who are are deficient. We currently are doing a trial right now giving vitamin D. So patients who come in the ED, what we're doing is measuring their vitamin D levels, and we're randomizing them to 10,000 units of vitamin D versus placebo. We're currently doing that now. We're looking at the incidence of acute lung injury. And what we're finding is that we have the largest vitamin D deficiency of all the trial sites in the country. Why in Detroit? Unique patient population, perhaps, but just another enrolling center is Ann Arbor. Their vitamin D deficient rate is only 25%. Ours are 50%.
Oh,
So
wow.
it's a lot of things that perhaps may come into play, but this whole vitamin D thing is now big, and perhaps do you add vitamin D to these patients as well? So the list could go on and on, but I think it's thought-provoking. Obviously, there's some attraction. There's a potential trial that's going to take place. But again, a lot of it is, why is an 80-patient study all of a sudden become
so huge? And that's the one thing that keeps on being, mentioned over the internet as well, where people are giving reviews on the article, was mainly it's a small study and there's really no data that could be reproduced on a larger basis as well. And then being 47 patients, yes, you don't see any adverse effects, but when you go on a larger scale, about 1,000 patients, will you start seeing adverse effects of some of these medications? Then is the bigger question.
Now, what was the mechanical ventilation rate between groups?
I think it was 20. So 22 in the treated group and 26.
What's that percent?
47%, 55%.
That's a good measure of illness. Mechanical ventilation is about 50% in most septic shock patients. So they're fairly sick patients. So you want to make sure that these are sick. They're fairly sick.
Okay. Yes.
Now that you read this article, would you do this in your ICU now?
So I actually, before I did an in-depth search on the article, when I initially had read it, I had tried it on 2 patients, and my staff at the time was a proponent for the article, and actually there was good outcomes. But after doing this much research on the topic itself, I would say it still needs more data before it's convincing and go prime time.
What are your thoughts on what contribution the hydrocortisone had? Was your 100% contribution? And your vitamin C, they don't have vitamin C alone, right?
Yeah, so like I said, so about 56% on the control group had hydrocortisone as well. So they still had a pretty significant high mortality. As to what caused that mortality is the question still up in the air. But at this point in time, it seems like that there was a significant decrease. Now, as to how many patients got thiamine in the control group, control group as well, that's not mentioned in here.
Well, there probably wasn't enough patients to look at the subgroup that had vitamin C only, right? That didn't
No.
have hydrocortisone?
No. So, no. So they didn't match the patients that were just without the hydrocortisone, no.
So
That
you
was-
can't really draw any conclusions with regards to vitamin C at all because of that hydrocortisone.
Yeah, because that was half of their patient population. Yeah.
The Thiamine and Vitamin C heal, right?
It's all IV.
Also, the historical control meant that they were doing standard of care before they decided to give vitamin C, right? So why were they measuring vitamin C levels historically?
So they historically
Check vitamin C, they were checking. That's not a standard. Check
No.
heal.
It started after those 3 patients that they had initially, and then once they started as a streamlined treatment protocol in their own hospital.
I thought the historical control was before they started vitamin C at all, right?
Yeah, so the control group, I don't think they got vitamin C levels.
Oh, okay. I thought you said-
So it was only in the treatment group that they got vitamin C. Yeah, and that's when they started giving it as a protocol.
I mean, it's easy to measure all these. So you can measure vitamin C, you can measure thiamine levels as well, and then you can do a stim test. So at least if you do those tests and you look at your baseline numbers and say, well, perhaps they're deficient, but what if they weren't deficient? What if they were basically at normal levels? that a trial be so prolific and be quoted so many times. It's just basic study design things should have been done.
Yeah.
Get out there and say, well, I want you to do a randomized trial because I think the therapy is so strong.
And I think that's another thing is that they didn't specifically mention what the baseline vitamin C levels were, even though they keep on mentioning that it gets lowered in sepsis. There's been experiments that have been done before that do show that it gets lower than their baseline of hypervitaminosis C is 25, gets lower than that in sepsis, but not this article, and neither did Fowler's article, which is like he's done in burn patients. None of them actually mention what the actual levels are of vitamin C.
Now there are studies like randomized trials using selenium, which is an antioxidant, inhibits myeloperoxidase. But there are multiple studies that have gone down the path of vitamin C, quote unquote, like substances. They've been negative. So I just don't know what's unique, perhaps, about vitamin C. Perhaps it is benign, but there have been studies that have tried to use the antioxidant route in sepsis, and there have been
No improvement. I mean, so one thing that they did mention before, like I said, was all these synergistic effects it potentially has with hydrocortisone. Could be the case, but that, like Dr. Jennings said, is that they didn't really give us the data without the hydrocortisone, so we won't really know. But one thing that was mentioned in other experimental articles that if you were to give hydrocortisone alone or vitamin C alone, these effects would not be seen. So they're saying that this is potentially a synergistic effect.
Did they comment on whether any of the patients have alcohol histories, or
No.
they try to exclude people who are malnourished, or
The only,
at least suspected
yeah,
malnourished state?
that's all they were excluding was patients were like the three here, but anybody that had DNR, DNI, as far as their code status was concerned, they excluded.
But you said that they were not sequentially enrolled. What was the reason? What was the criteria for them enrolling those controls?
So that's one thing that they didn't talk about either. They just said that there were non-concurrent enrollments in the study. So they specifically didn't mention, like, I guess maybe you got a septic shock patient one day and then a week later you got the second. I'm sure that's exactly how they enrolled them, but they didn't have.
Theoretically, it's enrolled like randomly for no reason, as opposed to usually should be, subsequent patients coming in each time.
And then they took.
Evaluated for inclusion and exclusion. But if it's spot check, that could really bring in bias.
Yeah, one thing. Yeah, that's a very good point. If you look, what's the duration of the trial?
So 4 days.
But what was the duration of the enrollment? How many months?
7 months.
So if you look at 80 septic patients in 7 months, an average 250-bed hospital sees about 300 to 400 septic shock patients a year. So you can kind of deduce basically how they pick their patients based on, say that the equivalent, they see 500 patients a year septic shock, and they only got 80. And you can kind of make a deduction that this is a convenience sample, not a randomized prospective, enrollment. So it's likely that it was a convenience sample, perhaps from 8 to 5, 8 to 6, in terms of
enrollment.
People available to enroll patients, and that's how trials are done a lot of times.
Hopefully not cherry picks.
Yeah.
Because just the time of day can make a difference in terms of outcomes from septic shock. Whether you enroll 5 days a week versus weekends, that difference makes a difference. Weekend patients tend to do a little bit worse than weekday, patients. So it's a little different in terms of that. Now, your procalcitonin levels are interesting because there's an interaction between renal failure and procalcitonin. As you know, patients in renal failure, their levels don't necessarily go down. So you almost have, is it cause and effect because they got more
Renal failure in there.
Therapy, the procalcitonin levels didn't diminish. That may be an interaction perhaps that's not related to, to the obviously affecting the patients.
Okay, yeah. So they had equal amounts of AKIs though. So it looks like 30 patients in each group, 31, 30. But then the amounts that required renal replacement. So I guess the severity of the AKI is what we don't know about.
But you can see that they got one on dialysis.
Yeah, 11 on dialysis.
Yeah.
So it's definitely there. So I guess the consensus here is that nobody's going to be using vitamin C in sepsis at this point in time, I guess.
So if the patient was getting ready to check out, that means, would you say, are you asking us if we would give it to a patient?
Yeah.
I mean, I wouldn't see a problem. I mean, if you got a patient on 40 mics a week with vasopressin, ARDS, I mean, most of the time they're going to get steroids anyway. So the thiamine levels are, as you know, that's what you're going to do most people if they're alcoholics. And so the only thing is the vitamin C. I don't see a big problem.
Can't hurt.
Yeah. So that's why I went. Yeah.
I think definitely not, but with this data, but the question for the future would be harmless medications like vitamin C. With such a study, not suggest, maybe, with such a study, give us the right to do a larger randomized trial. It's such an available medication that's known to be harmless. We need like a very large amount of patients to convince with specific outcomes. I think the outcomes that we have here are not going to have an outcome reduced mortality in those patients. So even looking to the outcomes, we might think, what are we looking for? Like when you're using the vitamin D, such an available medication, and your outcome is if you want to didn't discuss mortality. But I don't know if this should justify a large clinical trial. I don't know.
Oh, I'm sure that it will be, because you're right, no drug company would underwrite a trial like this, so it have to be NIH sponsored.
Yeah.
But it all comes out to equipoise, meaning that are you willing to hold the therapy in the one group and currently give it to another group if you're going to prospectively examine it. Right now, you can do a study because there's no. But according to Merrick, he says it's unethical
To continue.
But just to give you an idea, this guy actually is a plaintiff expert for suing hospitals.
Oh.
He actually in court, stated against a hospital in South Carolina that there was malpractice associated with this, and in court. So there is some
bias
in there.
Yeah.
It goes beyond science, but just let you know, he sues doctors.
One thing he did specifically mention over that interview was that his own hospital's mortality rate in the ICU has gone down from 0.69 to 0.33. Exactly, if that's a percentage number, it went from 69 to 33%. That's a significant drop. I don't know if they're just now more aware of sepsis, maybe, or what's going on, but that's a huge drop for just vitamin C. I just can't believe that.
Yeah, it's a military it's a military base, and I'm not sure what patient population they see, but it is a military hospital too. So
His argument for not doing randomized controlled trial was because of the lack of equipoise at a center, but they only enrolled 80 patients over 7 months. So that alone, when you hear him talk about the article on news media and social media, just that fact should bring up the question of how much bias is involved. So I mean, you have to caution it. I mean, like Dr. Richard said, in the most severely ill, if they're going to die, I've used it. And last time I used vitamin C on a patient was I had a young kid on ECMO who was a maximal pressors, but 4 or 5 different pressors, and we gave Thiamine anyways. We gave hydrocortisone anyway, so I threw on the vitamin C. But do I think it made a difference? No. I think the aggressive care that we gave overall was probably what pulled him through.
Yeah, I feel like we're kind of stuck with this because we likely know that nobody's going to want to pick up a trial that we already have available in almost every ICU. So you're kind of stuck with, is this going to be the biggest trial that's going to come out of this? And then you're thinking that with the outcomes that they had, a significant drop in mortality, that's a percentage of the drop. So you're not thinking about it in some of your cases where they're about to die at the end. So it's always going to kind of bring up where it would have to last. As there's high risk for our people, whether we see this try to say it honestly, I think we're kind of stuck. If it doesn't have good data, but then if they're going to die, how long do you
Obviously, the question is this the next meeting group?
Is this the next cycle?
When nothing works, we just check for vitamin C.
Maybe we'll find out if
And that's like another thing what people are saying is how small the study actually is. You can potentially make data go swing any way that you want if you do it repeatedly enough times, and then you only put that data out there. So I don't know if he's potentially tried something else before, or like Dr. Jennings was saying, maybe he just included some things that he was showing things in his favor, potentially.
Where was it published, Mohammed?
December 2016.
Where? Chess?
Yes. But like Dr. Rivers is saying, it's like it's been rejected by multiple journals.
And I think the rejection thing, there are lots of good, the first trial almost got rejected from the New England Journal of Medicine because of like the p-value. So that I think alone I think it's more that there are definitely things missing. There's missing data, it seems like there's a lot of missing information. Maybe this study, in terms of power, may not be convincing. I think we concentrate on that.
Yes.
So I think Justice Point, when you have somebody who's dying, a lot of people who are echoing that. That's like a compassionate use scenario. That's a distinct, level of evidence requirement from whether or not you do a prospective trial of the current standard of care. I don't think this necessarily precludes a prospective trial against the current standard of care on ethical grounds of depriving people of this because the evidence is so good. I don't think this evidence is strong enough so you can't do it.
Yeah. As a last-ditch effort.
We are depriving our entire employee health system of.
And there are randomized controlled trials. There are two. There's one in Europe and there's the NIH sponsored one here
on
vitamin C.
Are these Montego or
No, that's vitamin E. The vitamin C, there's one that's going to, I don't know. There's definitely, there is a discussion in the design stage with the NIH, and then there's one in Europe that seems to explode.
Did they lose any enrollees during the trial? Did they lose anybody withdraw consent, anything like that?
Not that they mentioned.
Zero.
Zero.
Oh, okay.
They were coming in with sepsis, so maybe they were encephalopathic or something. But they didn't need consent. It's implied.
Now, was it blinded? Was the drugs blinded? Placebo wasn't blinded?
So, like I said, basically they had the control group was a 7-month period, and then I guess after this 3-patient window, they kind of just adopted this protocol, and every patient from that point onwards at the hospital started receiving the cocktail.
So your control was a before and after control?
Yeah.
And that they accumulated the controls and then they switched over to
yeah.
vitamin C in every patient?
Mm-hmm. The majority of them. So they didn't specifically mention that the doctors were being blinded to, giving something or not, because that's what people are arguing against. Like, everybody got the treatment in the ER, or that was their protocol to start the treatment in the ER if they got the diagnosis of sepsis or septic shock.
So it could have been forethought effect. People may have changed, knowing that you got vitamin C, steroids, or whatever. You may have gotten more aggressive with your patients as well. That's a variable that perhaps can interact.
And that's, I don't know, maybe because their center's getting more publicity, so they're acting in a different manner now, potentially. That's it.